Hello, listeners. This is Yukta speaking, your host for today's episode, which is a talk given by Dr. Cherian, co founder at Synapsica, on the topic taking a deep dive into AI in healthcare deployments. This talk is a part of the 12th IC Innovator Club virtual meeting hosted on the topic What It Takes to Do Real World AI Lessons from Deployment. Let us hear from Dr. Cherian.
Thank you, Sachin. You were right. Rohit's session was really very informative and leaves very little to build on. But yes, there are some points I would like to talk about. But first, a brief introduction on my part. I'm Dr. Cherian. I have completed my medical education from AIMS, and post that I have ventured into entrepreneurship field for uh, like more than 7 8 years now. And at Synapsica, I am leading all the conceptualization, design, implementation of all the medical products, how to go about solving a problem and choosing the problem, solving the problem, deploying it, and taking feedback and improving. That's my role at Synapsica. What we are building at Synapsica is we have a couple of AI algorithms. One, Sachin mentioned, was assistant on chest X-ray, but the more unique and a niche product that we are building are AI algorithms that read spine imaging and improve the efficiency of radiologists in reading those cases and bringing more objectivity and quantification to these interpretations. So to the set of questions that were shared, and probably the chronology of questions in which Rohit answered, I'll take them in that sequence. And Rohit did mention that data is more important than algorithm. And I would like to slightly differ here from Rohit. Data definitely is more important, and every AI company is hungry for data because, like as Rohit mentioned, plugging in data would definitely lead to improvement in that algorithm, and that last mile journey of like going from 90% to 95% accuracy is tough and takes the longest amount of time. But the way we approach it is that. And it somewhat resonates with the idea Dr. V.K. Singh said earlier, that AI is like any other tech. It is continuously improving, and there is always scope for improvement. But when we start to build a tech, what we do is we define a scope of the product and what's the intended use uh, um, to which the AI would be put to, and what do we expect out of it. It's like any tech product. When you start building, you have to define these things. And the current version of our spine reading algorithms, which are designed for objectivity and bringing efficiency to the reading and interpretation workflow, are trained on more than 75,000 images and 75,000 exams of MRI spine collected over from like multiple sources acquired through various different machines. So these algorithms are like in currently deployable stage, and are ready to be deployed. But how do we reach that decision is when coming back to the point that when we started, we clearly had a defined objective that, hey, we want to reach here, and we need to walk that fine balance of inputting more data into the AI and not forgetting about what we want to achieve. So all of the data that we have currently is sufficient for the goal that we have set out for us. Obviously, we would want to have more data and expand our data set to develop more features and more capabilities to our AI, and improve the existing capabilities that we have. And coming to the challenges of expanding the data set, I think Rohit covered most of them. One thing that I would like to point out to the audience who would, as Sachin mentioned, who can take away these feedback and maybe use it to refine their own process in AI building, and to other audience maybe to understand better how an AI company thinks is an internal issue, and what happens is it's not about just acquiring more data. The data itself costs a lot to be input into the system. I'm not talking about sourcing, but the data preparation, the objective ground truthing of the data cleaning, and understanding how it will change your AI system. That itself is a very costly process, and not just only in terms of money, in terms of time, uh, and, uh, and you need to walk a fine balance between what will you want to achieve in sync with the goal and in sync with the goal and intention which you started out with, and how much data you want to input into the system. So that fine balance is required to be very cash efficient and cash prudent in terms of talking from a business standpoint, and also from a medical standpoint. Plugging in more data doesn't necessarily mean that there will be improvement in performance of AI. That is where I differ with Rohit in the first place. That uh, Rohit mentioned that if you plug in more data, the improvement will be, you can see the improvement going up, but that's not the case. Even after a certain amount of data being plugged into the system just stops learning. And there comes in the skill of the team, the core capability of the team, wherein you can build newer algorithms and newer innovations, bring in newer innovations in technology that can leverage that learning from the additional data set and bring and develop more accurate algorithms. So like I have read a formula written by someone, and we internally believe it to be true and follow it. So like the accuracy of AI algorithm is is the quality of your neural network multiplied by data square. So obviously data is a twofold factor here, but yes, quality of algorithm is something which definitely impacts the end output, and there is a lot of scope that you can do there, and that's where our primary research is focused. So moving on to the next question of how do you measure a completeness of data set? There I completely agree with Rohit that there is like no clear way to measure the completeness of data set. What you can do instead is, again, going back to the intended use and the scope of your tech product. If you have clearly defined scope, so for example, with our products, when we set out, we wanted to bring in, so generally a radiologist would taking example of MRI spine, radiologists would take anywhere between 10 to 15 minutes to completely read the MRI spine exam. We wanted to reduce that time from 15 minutes to 5 minutes. And that was our initial goal, setting out, and we measure the completeness of the data set in that context. And we think our data set is complete when we are able to actually achieve that. And to that, I would say that a real-time clinical setting trial is the only way to say whether your AI is performing well enough on the data it has been trained, and that indirectly means that your data set is complete. Moving on to the next question, that's how do you ensure objectivity in ground? That's really a very important questions for startups and businesses who are working on AI. And Rohit captured it very succinctly that in a real life scenario, there is a lot of subjectivity and inter-observer variability that happens between radiologists while reading the exams. And what you can do is go through multiple rounds of annotation. That's same we do here at Synapsica. We go through multiple rounds of annotation, take consensus among multiple rounds to achieve an objective ground truth. Because like to take a crude analogy here is that AI is like a dumb kid, and if you want that dumb kid to excel in clinical trials, wherein it is tested against multiple radiologists, you would have to handhold the AI to learn from multiple radiologists. rather than a single radiologist, and then be benchmarked against ground truths given by multiple radiologists. So that is one fairly straightforward way of bringing objectivity into the ground truth that gets fed into the AI system. But the second, and I think uh, that is a way we have defined our products. The second is, I think, the approach that you can take to prepare your data in ground truth also helps a lot in bringing the objectivity. So what we do is, uh, so what we have observed is generally that if there is no limitation on skill, then the observation that a specialist would make while looking at the images are fairly consistent. It is the interpretation of those observations where the variability comes in. So if, for example, if you see a lesion or maybe a shadow or some artifact in the image, everybody is able to see that. Everybody is able to see that, but what you make of that artifact, whether it is, lung cancer or TB or maybe something else, that interpretation is generally very subjective and has variability. So how we have thought of approaching this is, why don't we go towards identifying the observations themselves rather than predictions? And when we go after those observations, picking out observations is fairly objective when one looks at the images. People are able to look at the image and identify, hey, there is this description, and then use that description in context of existing medical criteria to come up with interpretation. So what happens is, you have a good objective ground truth evaluated against established medical criteria to give out the final interpretation. And this also helps in creating a more explainable AI. So a radiologist or specialist looking at the images and as well as the results of AI would know, hey, these are the observations that were captured, and on the basis of this is the result that AI has given. Even if the AI has made a mistake, they know that which observation was interpreted or which observation was picked up wrong, and because of which the final interpretation is incorrect. So that is a second way we are tackling objectivity in ground truth, changing the approach to behave more like humans rather than being a black box and just predicting something from raw images. Obviously, there's a trade-off in this, and we are aware of that trade-off and have made a conscious decision. The trade-off is that when you input only observations from human, the AI is not able to learn from things that a human eye cannot see. There are a lot of correlations and a lot of hidden features that impact different weights and biases of different weights and biases at different decision-making points, which finally might lead to AI being better than human. But that's a trade-off of developing a more objective ground truth and having an explainable AI. And I think that covers the some part of the next question of the results that our system provide. Are they explainable or interpretable for a clinician? Guess again, objective observation being output, being the output of AI, and forms the basis of being forms the basis of overall output given by AI systems being more explainable and understandable by the radiologists. And again, as Rohit mentioned, that this AI, the format of AI outputs becoming fairly common, and radiologists are getting used to. So it's always best to go after what's most sought of, what most common, and not reinventing the wheel. So most of the AI companies, what they're doing is they are preparing annotated images, highlighting certain areas, masking pathologies, so that radiologists are able to see, localize, and understand what the problem is. And apart from providing annotated images, what we do is we give a feature of interactivity to the radiologists, and uh, that we think is important, because not all results of AI are going to be accurate all of the time. And if we are to make a true assistant to a radiologist, then there must be some way for radiologists to interact with the results of AI. We think of radiologists, like internally, we think of radiologists of we think of AI as being a junior radiologist in training who prepares a report, and then a senior radiologist looks at the report and makes changes. And with the interactive tool, what we want to do is make that process of making corrections on the results of the junior radiologist much more easy. And in the process, what happens is, if the radiologists interact with the AI and change their results, we immediately get a feedback that, hey, the results of AI in this flow was changed, so there must be some problem, and that gets taken into the feedback cycle. All of such images, all of such cases and pathologies where changes were made are collated automatically and collated automatically and categorized, because we already know for what reason changes were made, and we are able to assess where we are going wrong and what areas need to be improved. And it gives us a food for thought and next action items on how to go about improving our images from the interaction results from the with the interaction results from the radiologists. So I think, yeah, that answers the next question as well, as to how we are taking on the how the AI system is taking on the clinician feedback and how we are improving on it. So it kind of gets automatically done through the interactive feature we have, and that information that we get improves the performance of the AI going forward. And going on to the next question, that is, how does your deployment change the care pathway, and is it possible to retrofit? Yes, the system is able to retrofit and integrate with existing workflow, and that was one of our main concerns, that the radiologist should not be switching to different systems while looking at the results of AI, because all efficiency that is gained from AI will be lost in switching between systems and looking at various panels to interpret. And a clear and tight integration with the existing workflow is important, and it's possible to retrofit our solutions. But to the answer of changing the care pathway, I think in the first step, most of the AI solutions will improve the efficiency of the existing pathway, and in the next step, possibly go on to changing the overall clinical care pathway that there is. Obviously, the difference being some of the screening exams, like mammogram screening or CT lung screening, wherein a cancer needs to be picked up, and there a bulk of volume can be processed by AI, and it can really change the care pathway. But those are things which are in early stages, very promising, but early stages, and that will definitely come. To the last question, I think, how does your system bring efficiency into the clinical process, and does it improve quality of decision making, automation, etc.? So what our system, our AI is able to do is that one, it focuses, as I said earlier, it focuses on improving the efficiency of radiologists in reading and interpreting the spine exam. That's our main focus, and there we are able to reach our goal to reduce that 15 minutes time taken to 5 minutes, 7 minutes for routine cases by radiologists. And what it involves is, it involves a lot of automation on the manual processes which a radiologist would generally spend while reading such exams. And and if you ask a radiologist, like nobody wants to read a spine exam just because they're tedious, laborious, because it involves a lot of manual work. And we think that helping radiologists with uh, a drudge work like this would also impact the burnout which happens among specialists, and which is very true for radiologists. A lot of radiologists, almost 50-60% of radiologists feel burnt out at least one point in their career, at least one point of time in their career. And uh, removing that manual and tedious process will help that. The second thing which impacts the patient outcomes is AI is able to increase the sensitivity of a lot of pathologies that are present in MRI spine, gets missed uh, uh, by a reading radiologist. For example, uh, if for example, there are studies that say that almost up to 30% of osteoporotic fractures are missed in MRI spine, and they are not picked up in early stages. And when they are picked up at late stages, either the patient has suffered a lot of pain during that period, or due to or the treatment is delayed, which might lead to more costly and more invasive procedures. And if we are able to increase the sensitivity of picking up these pathologies using AI, that's going to help a lot of patients along the way. But wrapping up, I think just finishing on my time. So to the last question, these are the values that I have spoken about, but do clinicians perceive the gain to the extent you foresee, and what can you do to build the consensus on the impact? So here, building consensus is a difficult thing, especially when taken in the context of that radiologists who are used to working in a way for a long, long time. Their complete training was done in a different way. Now, when they have resumed work and have worked for a long amount of time, you come in with AI and ask them to change their behaviors of how they work. That is the most challenging part, I think, that's there. So uh, one thing that you can do is that you can have established proof of accuracy of your products that's going to inspire some confidence with the specialists to use that product. And the second thing that I mentioned about, so second thing that is focus on usability. So here again, repeating about our approach of making the AI interactive, because I think that's the most important point, wherein your product is very, very tightly and seamlessly integrated into the workflow, and they are able to interact with the AI results and generate reports very quickly, that actually see benefit in it. That is the most important part, I think. As a company, we are realizing that usability is almost as good as, if not more important than, accuracy in clinical scenarios. And to the big pilots that we are doing, wherein we have deployed it, like with a very large organization, I think nothing you ever say, do, or show will prove it unless you demonstrate it, and demonstration in their actual practices, and actual demonstration of how it helps them in their daily uh, in their daily interpretation and their business, improving their financial metrics. That is something which is going to bring in the consensus to adopt the AI more.
Thank you, Dr. Cherian. To watch the complete club meeting on this topic, visit the link in the description below. Subscribe to the channel to get instant access to all the podcasts. Follow us on social media through the links available in the description below. Thank you all for spending your time in listening to this week's podcast. Look out for a new episode every Wednesday, published on Google Podcast, Spotify, and Apple Podcast. If you are interested in hosting our podcast with us, fill the form available in the description below. Thank you once again. See you next time.